we really pivoted and developed a product that absolutely non-antibiotic, that goes in and destroys bacteria, fungus, virus. It removes the necrotic tissue, the senescent cells as well, and the inflammatory infiltrate, all in a single treatment. I could go in and extract the water out of that biofilm, and not just free water, but the molecularly bound water as well. It'll create an entire breakdown of the entire biofilm chain, denaturing it very, very quickly, and allowing us to just kill and remove the pathogenic properties. We do have full split mouth studies where it was one side was SRP, the other side was SRP with HybenX, and they watched 30, 60, 90, 6 months, and all the way out to 12 months. And even after just a single treatment, the SRP with HybenX side was over 3 millimeters better in probing depth than the SRP.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome, everyone, into this bonus episode of A Tale of Two Hygienists. I'm your host, Andrew Johnston, and thank you so much for making us a part of your day. In this episode, we have Wes Fields from Epien. And I know you're going to like this episode, but let me tell you why. So sometimes it's just so dang fun learning something new, and this is new. Well, at least it was new to me. I hadn't heard about Epien before I went to Under One Roof, and truly, if we're being honest, just because this is the way I am, I probably would have walked right past their booth, because I wasn't necessarily looking for their type of product. You walk by some of these banners, some of these booths, and you're like, okay, well, I know what that is. I have this already kind of in my office. All right, I know what this is. That's something that I was already told, no, I can't bring it into my office before, or whatever, right? This new product, this new company to me was something I wasn't even looking for. The product is called HybenX. I will tell you what, if I would have walked right by it, I would have been making a huge mistake. So let me tell you what you're going to learn today. That's a little bit different. You're going to be learning about wound care and wound management. We have these perio patients, right, that come into our offices and they have these chronic wounds. And so few of us are actually doing anything more than scaling and root planing and maybe some periodontal irrigation. Wes teaches us an alternative that we can do while those patients are in our chair, in our offices. As a bonus, because I am a skeptic, I did speak with several people at the show after we recorded this, and I went to them and I was like, hey, buddy, like, what do you really think about this thing? And these are hygienists like us. And they said, I'll tell you what, it's amazing. I didn't get one negative review, one negative feedback. And I'm kind of surprised by that, because you know how hygienists are. Like, we always have well, it's great, but, right? We talk a little bit later in the episode about what you can expect from a patient experience. But basically, our friend Erin, who's going to be on the podcast here in a few weeks, she described the way that the calculus gets desiccated with HybenX. And it's what we all dream about. Like, it's the reason why we love taking calculus off of people's teeth. And it really drove the point home for me that I should be taking this product, this company, more serious. Shout out to Erica Flateau for co-hosting this episode. And with that, enjoy getting to know Wes, Epien, and HybenX.
A tale of two hygienists.
Welcome back, listeners, to the interview portion of the podcast. We are live again. I thought we've said that so many times. We're live again at RDH Under One Roof, right on the exhibit hall floor. It is a little bit loud in here. You guys might hear a little bit of background excitement and some fun little din here. We are joined today by Wes Fields from Epien, not to be, as Erica says, confused with EpiPen. So, Wes, welcome to the show.
Thank you very much. Glad to be here.
So this, for me, new product, new company. So I am a little bit at a loss of where to even start, but probably company history, I would say. Like, who is Epien, and kind of what is your role within it?
Yeah, so Epien Medical, we've been around for about 25 years. Historically an R&D company, and historically, if we look at our core base, it's a regenerative medicine company. I am the Chief Commercial Officer for Epien. We cover all three verticals: the medical, the dental, and veterinary divisions. Nice. So excited to be here. We've got a Cellerant Award-winning product here yesterday that we just launched this year. So excited about that. It's getting a lot of recognition, and it's absolutely just blowing up in the market right now.
Quick question right off the bat. Here we go.
Yep.
same product for your vet versus your humans?
So, don't tell anybody, but basically, yes.
I mean,
right?
I wouldn't imagine it would be that much different if it is at all, honestly.
And we have FDA clearance. The product's HybenX is the name of our dental product. It's FDA cleared for periodontal treatment, caries and crown prep cleanser, and endodontic treatment. So on the pet side, surprisingly enough, there's a fair amount of endo that goes on, right?
There's even crowns that go on.
There's crowns that go on, but there's also additional, like a lot of the ulcer side of things. So feline stomatitis, things like that. The oral ulcer front, it is utilized in that way in the veterinary space.
Did you think that you were going to get into this space? Because watching you say stomatitis, I'm like, dude knows his stuff. I love it.
I thought I wanted to be a veterinarian when I was in college, and then I worked in a vet clinic for a couple of years, and I was like, yeah, I really don't want to do this.
Well, you're natural. I love this. So kind of get into maybe HybenX, right?
Correct.
HybenX.
Yep.
There's lots of different applications. Generally, it's a hygiene audience listening to you. Mm-hmm. So maybe, if you don't mind, just kind of a little bit of product background, some active ingredients, and maybe indications of why we would use it.
Sure. I kind of touched on the FDA clearances, but really, our vice president of R&D, Dr. Mike Bissara, he's a board-certified pathologist and a board-certified chemical pathologist, so kind of think toxicology. Former chief pathologist for the VA, right? So he knows his stuff in this world, and he was originally, kind of that late 90s, early 2000s. We're seeing the significant increase in antibiotic-resistant bacteria. In fact, just yesterday I read an article from the CDC that talked about the post-antibiotic era is today. And they quoted had quoted 1992 and prior, there was basically 0 infections of antibiotic-resistant bacteria. And last year there was over 3 million in the U.S. And that's the ones that they were able to quantify, right? So they're seeing a significant increase year over year. And Dr. Bissara was seeing this. He was specifically kind of looking down that medical space, regenerative medicine space originally, coming from that VA environment. And looking at burn victims, chronic wounds, grafting, things like that. Those failures and slow to heal, that's biofilm related as well. And he had that aha moment. He's like, wait a sec, the oral cavity is just chock full of biofilm.
Sure.
And we can pivot this technology into the oral cavity, and we really went kind of full force there. He was working with the Biofilm Institute up out of Montana, and specifically working with Dr. Bill Costerton, who, if you ever want to spend 13 minutes on YouTube, it's the father of biofilm video, and very, very interesting gentleman. And he was working with Dr. Bissara, and we really pivoted and developed a product that absolutely non-antibiotic that goes in and destroys bacteria, fungus, virus. It removes the necrotic tissue, the senescent cells as well, and the inflammatory infiltrate, all in a single treatment.
I'm really sorry to be the dumb one here, but how does that do that?
Yeah.
Seems, it's like, am I just going to brush it on and it just magically works? It doesn't seem to be that simple.
It doesn't. Well, one thing I'll tell you is that when I first started, because it does so many things, that I told our CEO, I was like, I feel like a snake oil salesman a little bit because it does too many things.
Yeah.
But the method of action is actually fairly simple. And Dr. Bissara talked about, he was sitting around one day with all the other MDs who were kind of working on this. And he kind of had that aha moment. He said, biofilm is sitting there in an unprotected gel matrix, right? That gel protects it against the body's resistance, right? So we get the dysbiotic bacteria in our perio pocket. The body sends the white blood cells, and very simplified model, they excretes toxins trying to kill the bacteria. But because it's in that gel matrix, it doesn't kill the bacteria. The body keeps doing that, which ends up damaging our own tissue, and then we get the necrotic tissue, and the pathogenesis just cycles, right? Well, Dr. Bissara's like, well, that gel matrix isn't protected. Like in our skin, we have the keratin layers in our skin which prevent water extraction. He's like, if I could go in and extract the water out of that biofilm, and not just free water, but the molecularly bound water as well, it'll create an entire breakdown of the entire biofilm chain, denaturing it, very, very quickly, and allowing us to just kill and remove, the pathogenic properties. And he talks a lot about, our bodies have really robust healing capabilities. If we just remove the products causing that pathogenesis and that inflammation, and just get that out of the way and let the body heal. Yeah. And that's essentially what HybenX does. It does it through rapid desiccation.
That's so interesting. I mean, because you do think in your mouth, like you get a burn, like on your cheek or tongue or whatever, and then 2 days later, it's like, oh, where was it? Not my mouth. Our bodies heal pretty darn quick. So that's good to hear. Is this more of a topical application, or is this like injectable? How does this work?
Yeah, it is topical. I mean, we have done full mammalian intravenous studies, as you can kind of think as we're working down that medical path. The kidneys flushed it immediately. There was no issues. I've got, I kid you not, dozens and dozens of fully independent studies. We've had the product in Europe for a little over 5 years with literally millions of doses sold. Good old COVID slowed down some of the FDA clearances and getting that stuff through governmental agencies.
Yeah.
But yeah, so we can go in and we can actually, treat both. If we're going to, let's say we're going to do a periodontal treatment, go to an SRP, we can actually go both pre and post scanning and root planing. So if we're going to go pre, we go in, we can actually place it along the surface of the calculus, let it sit for 10 to 30 seconds, evacuate and rinse. And in that time, it desiccates that calculus and also breaks down that biofilm, connecting it to the actual tooth structure. So it makes it much easier to actually do your SRP. The debridement is much easier.
What about subgingivally?
So, well, once we do the calculus removal, then we go subg. Any of those 4+ millimeter pockets that you need to go in and treat, or any pocket that you deem, you're the clinicians, right? So as you
So there's
deem
no
necessary.
max depth. I mean, you can go 12. Okay.
Yep. So yeah, no max depth. In fact, we recommend, right? So you go in and you fill the entire pocket.
And are you squirting this, brushing this on? How are you applying it?
You squirting. It's got a tip that you place subgingivally and you fill from the lowest part of the pocket to the gingival crest.
Okay.
Leave it in pocket for 10 to 30 seconds. Evacuate and rinse, and in that time, again, it's any bacteria, fungus, virus, the senescent cells, the inflammatory infiltrate, completely removed. Right, and a common question I get is, does it kill the commensal biofilm, the healthy biofilm? And the answer is it does. Right, it kills all biofilm that's in that pocket. But the independent studies have shown time and again that within 24 hours, that commensal biofilm is back in the pocket, and within 48 hours, it's laid down a very, very healthy layer of commensal biofilm. But since we've removed those senescent cells and that inflammatory infiltrate, so that inflammation's reduced, the food for the dysbiotic bacteria is gone, the dysbiotic bacteria does not come back in and repopulate.
Okay. So it now has an opportunity to thrive by itself without competition.
Exactly. Yep. Fibroblast cells are firing back up. And I mean, we see, and I've heard just in the show here consistently from hygienists who are already using the product, consistently they're like, wow, 30 days, they came back, we saw 2 to 3 millimeters of pocket depth probing reduction in 30 days.
Wow.
So you can treat a whole quadrant with a cannula of this, or how many teeth can you treat at once?
And so if we're doing it in an SRP kind of format, one syringe, so this does ship with 2 1 mil syringes per package. One syringe will do a full arch, going pre and post. And if you're kind of doing spot treatments, there was a hygienist that stopped by and she said, was telling us about an older patient she had. She's been working with him for a couple of years. He's a fairly heavy smoker. He had that kind of random 8-9 millimeter pocket. They've been throwing everything at it for a couple of years and it's still hanging in that, that range. I'm like, do we just extract this thing or what do we do? So they tried HybenX, came back 30 days post. He was at a 6, retreated at 30 days. He came back 60 days post that for his quarterly perio maintenance, and he was at a 3.
Oh my gosh.
So you can, if we're doing kind of spot treatments, each syringe is somewhere in that 30 millimeters of pocket depth used per syringe.
Tell me about this. I know you didn't see the patient, so it's probably a little bit hard to speculate. But a 9 to a 3 seems unlikely.
I would agree.
How, I mean, because there's no bone regeneration happening at that point, right? So is this now the height of the gingiva is coming so far down now they have 6 millimeters of recession exposed, or
good question.
How did that happen?
So I can tell you, and we've got dozens of studies, a lot on periodontitis as well, that actually does show bone regeneration. And I actually have, I won't share his name, but he's a significant speaker around the country, a doctor who currently practices, and he's not on our paid list of speakers or anything, but he speaks a lot about HybenX. And he shot me an email and shot me his radiographs. He's like, I can't explain this, but within 30 days, I've had almost 2 millimeters of bone regeneration.
Was it around an implant?
Nope.
Oh, okay.
And if I'll be happy to show them to you as well.
So I feel like this is the body regenerating, not necessarily HybenX.
The HybenX
does not regenerate bone.
Does not.
Be very clear about that, audience.
Yep.
It doesn't. But it allows maybe for your body to do some regeneration.
Exactly. We're just getting the crud out of the way that's halting our robust healing capabilities that we have, right? So getting that pathogen stuff out of the way. Yeah.
Okay. So if a hygienist opens a cannula of this and uses it in a spot treatment type of format, then can they save it and recap it? And does it now just stay with that specific patient because of infection control? And this little guy keeps coming back in, this 80-year-old with his 9 millimeter pocket, and you keep it in a baggie for him? Or, I mean, do you have any idea how that works for spot treatment?
Great question. And I can tell you, we ship it 2 syringes and 2 tips, right, as kind of a single-use product. But we hear consistently from offices that they kind of utilize it like they would a varnish or an etch, right? So if they'll place it, dispense of the tip, wipe the syringe, and whatever their infection control protocols are.
Got it.
I think that's the best thing. Is like whatever your infection control protocols are, as long as they're in line with all the regulations and stuff, you're probably good to go. But
Right.
to your second point, though, Erica, about storage, because there are products out there that are maybe light sensitive or things like that. So talk to us a little bit about temperature, light, all of that.
Yeah, so just room temperature storage, no need to refrigerate or anything, no light sensitivity, about a 2-year shelf life for the product. So it's a very easy product to manage within the, your inventories.
You mentioned that the patient before came in 30 days. Is that the recommendation is that you apply this every 30 days as needed, or is there a cap? Is there a small amount, whatever?
Yeah, no, there's we don't actually have a standard kind of protocol for treatment.
Okay.
It really do leave that to the clinicians. We're not seeing the patients. We don't know what that site looks like. It is a non-systemic product, so at 30 days, if you feel a need to retreat, certainly feel comfortable retreating. There's not going to be any negative side effects, due to that retreatment being non-systemic. We do have, full split mouth studies where it was, one side was SRP, the other side was SRP with HybenX, and they watched 30, 60, 90, 6 months, and all the way out to 12 months. And even after just a single treatment, the SRP with HybenX side was over 3 millimeters better in probing depth than the SRP alone.
Incredible.
And they just watched all the way out to 12 months on that one with a single treatment.
And the CDT is letting you submit this on like a 4381?
Correct. Yeah, we did. We met with the ADA, kind of walking through the product, its method of action. I was like, so what are the standard codes, that the offices can use? And he made it very clear that the clinicians, these are procedure codes, not product codes. And if the product meets the definition of that procedure, it can be utilized. I can tell you, we hear from a lot of offices that the 4381 code's one that they'll utilize, 4921 where they'll implement that into quadrant irrigation, where maybe they'd used chlorhexidine in the past or something, they'll transition over. We do have 2 viscosities, a gel and a liquid. Clinically, they're the same. It's really a clinician's handling preference. And when I say liquid, don't think like water, think more like a glycerin kind of a consistency. Because the viscosities do make a big difference. So obviously we're working through desiccation, but like our gel's 1,400 times the viscosity of water. And both products, our liquid's about 700 times the viscosity of water. So if we're doing a periodontal treatment, that helps lift and remove the debris out of the pockets as well. And the other thing is it's a very, very dense product. So if there's water, if there's blood, if there's saliva within that pocket, the density will drive it down past and through the water, blood, saliva. So we treat that entire pocket. And by the way, it's also hemostatic, right? So it'll shut the bleeding down.
Which is crown and bridge is why they use it there.
Yep.
In addition to
preventing
antimicrobial.
secondary decay.
Yeah.
Eventually, and exactly shut down the bleeding, the troughing.
Well, you actually said something that I was thinking this is going to be more soft tissue, but do they also rub it on their entire prep for secondary decay?
They do, yeah. FDA cleared for that as well.
I love that. Is this a take-home product at all? I mean, is there any time that you'd say, hey, we didn't use it all, go ahead and finish another thing? Okay.
Because we do have, some fairly standard, apply it, evacuate.
Yeah.
The one negative to the product is it doesn't taste good.
Oh,
right.
Sure.
So it's kind of, to me, it's got a very kind of
weird.
bitter,
A dental
sour
product that does not taste
Most
good.
things that are good for you don't.
Yeah, very true. Kale, I'm not a big fan. Right?
I'll tell you the best recipe for kale, though, after the show. It's going to change your life.
You can do a whole podcast on that.
Oh my
People
gosh.
love it.
Yeah.
Well, so as a hygienist, and I want to institute this with my patients and talk to them about the benefit and the cost, and what would be a great way to open the conversation with, oh, this is something new. Why are you doing this now?
Yeah, I think I heard a quote recently that said, the Stone Age didn't end because they ran out of stones. Right? It ended because they came up with a new technology that worked better.
Yeah.
And I think all things in our lives are progressing on a regular basis, right? So it's like, look, we've got a new technology because we are a registered medical device, not a drug, right? So it makes it a little bit easier for everybody to utilize and use. But it's like, look, we've got a new technology here. It works, very, 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 very fast, in comparison to other products. And very safe. And the other nice thing, this compared to other products, we have no post-treatment restrictions or instructions for the patient. So it does its job while they're in your chair. And whenever they leave, they can go back to kind of living life as usual, flossing, brushing, chewing gum, whatever it is.
Yeah.
So we've got a product that works a little bit, better in our opinion for your patients. And for the practice, it's very, very competitively priced, so it's a great option for the practice as well. I mean, it's significantly less expensive than competitive products.
Do you feel like there's any over-the-counter solutions okay, so I apply the application today. The patient goes home. Is there a better pairing of mouthwash, toothpaste, floss than others, or is it pretty much it's done its job? You can do whatever works for you.
Yeah, that's where we're at, right? It's done its job, and you as clinicians, if there's a product which you have found to be successful and you'd like to implement as an additional adjunctive treatment, feel free, right? That's not going to cause any issues with what our product has done and the outcome there. The one thing that we do recommend is you wait at least 48 hours for the patient to start that additional adjunctive treatment, primarily because we want that commensal biofilm to really have that 48 hours to lay that nice healthy layer of commensal biofilm in the pocket.
Yeah, and any other contraindications we would want to know about?
Great question. Yeah, so the only contraindication which we have listed is if somebody has a sulfur allergy, not sulfa. If they've got sulfa, no problem, but a true sulfur allergy. And the reason for that is the primary components, the active ingredients, there's not an ingredient, it's a combination of a handful of ingredients. And this to me is some of the genius of Dr. Becerra, but it's a combination of sulfonated phenolics and a sulfuric acid. And they produce an exceptionally high electrostatic charge. That's why it's able to strip the water off of the other bacteria, fungus, virus, etc. But the first time I heard, oh my gosh, it's got a sulfuric acid in it, it's like, oh, it's highly caustic, right? It's doing chemical cautery or something. And Dr. Becerra had to take me back to my physical chemistry 101 days and reintroduce me to the fact that highly concentrated acids, which is what we utilize here. So these are highly concentrated sulfonated phenolics and a highly concentrated sulfuric acid. It doesn't release hydrogen ions at all, right? So pH is potential hydrogen. Acids release hydrogen, bases absorb hydrogen ions, but highly concentrated acids literally have no pH at all, right? Because they're not doing that transaction of the hydrogen ions. So you can take it and test it, and not only is it not acidic, it's not basic, it's nothing. There's no measurable pH within HybenX.
So if I touch somebody's veneer with it accidentally, okay?
No problem. Safe on dental metals. It's a very, very safe product.
So let me ask this. So the pricing that you've seen in the offices that from your feedback, because you mentioned two different codes, and those two codes have drastically varying pricing. Mm-hmm. What could a hygienist expect the patient cost to be, or what have you seen as far as a range of cost for the patient?
I can tell you typically on the per tooth antimicrobial code, the average that I see, hearing back from offices is right around $60 per treatment. Mm-hmm. Some are a little less, some are a little higher, right? But on average, that puts it right in the ballpark.
So, which is pretty much average for the alternative products that are out there.
Correct.
Of 60. Okay.
They really don't change necessarily their price to the patient too often, but I mean we're talking 70+% less expensive than competitive products. So one of the things which we recommend a lot is come up with a good, better, best periodontal treatment plan.
Yeah.
Because case acceptance is king, right? If the patient doesn't say yes, first they don't get the treatment and the help which they need to defeat this infection. Mm-hmm. And second, the practice doesn't see the revenue generation from that additional service that can be utilized. So maybe is it 1,700 and 300? I don't know. Whatever the practice deems sufficient for their plan, but come up with some layers or some opportunities to be able to present to the patient to get some more yeses and provide additional treatment to the patients.
No, I love that.
When you said one treatment, is that the 2 syringes, or one treatment is one application per arch? So would it be $60 times 2 on average for the whole mouth, or if you were doing 4 quadrants of scaling and root planing, or?
Yeah, obviously that's key to the procedural code, which the procedure which you're doing, right? So the 4381 is a per tooth antimicrobial. So that would be if you've had 4+ millimeter bleeding pockets, that meet the definition of a periodontal pocket, that'd be times 4 for that. The 4921 code, that's your quadrant irrigation code. Mm-hmm. So that would be a per quadrant fee.
Okay.
Mm-hmm. Any last thoughts for our audience that you might want to talk about?
It's just really exciting. It's not just a new product. It really is a new technology that we brought to dentistry. It feels like I've been in dentistry for a long time, and it feels like anytime we hear, there's a new product, it's really the latest generation of a product, right? Yeah. We added nanoparticulate or something, right? And so everybody's very familiar with it, and it's historic. But this is not just a new product, it's a new technology we really kind of looked at from the regenerative medicine space and applied it into dental. Again, as we're looking at the future, this continued increase in antibiotic-resistant bacteria. Like I said, the CDC's talking about, the post-antibiotic era is now, was this recent article. We just kind of keep seeing this. So the more focus that we can have and the proper stewardship when we need to use antibiotics that are the proper time to utilize it, those are wonderful, right? But when we can have another option to provide a great treatment to our patients, let's take advantage of it. And we're excited to bring this to market.
And if it makes calculus easier to remove, you're going to have a lot of fans around here.
Yeah, for sure.
So how might someone learn more if they wanted to learn more?
Yeah, great question. So you can go to epien.com, EPIEN.com. We've got dozens and dozens of studies on our site. We've got how-to videos on our site. And that's the easiest way to take a look.
Awesome.
Okay.
Wes, appreciate you being here. Thank you very much.
Thank you.
Awesome.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.